Hi, Ibrahim, one of the estates in South Wales. Today's lecture on maximizing performance in intermediates. On the side, there's a QR code for my X account. I'm running for a Specialty Advisory Committee representative role in the Rota election. So please subscribe. If you know any local trainees or if you're a trainee, vote for me and share with your friends. Would be much appreciated. Back to business. So we're talking today about day one. So for day one, resources like Chesterfield Clinical Course, Said Fazal Ali book help you prepare effectively. You need to practice in a group and practice as much as you can. So it becomes like a second nature. So practice examination technique until that is a second nature. Attend specialist clinics to refine your skills and engage with consultants to simulate the real exam scenarios. Remember to remain calm, listen attentively to your patient, show a high order thinking in your interaction with your patient and the way you're phrasing your questions and how this will affect your management plan. And we covered this in my previous lecture when we started the revision. Just a recap, the patient interaction is a key. Listen carefully to the patient, show high order thinking in the history taking. This is mainly on their function assessment, expectation, concerns, what previous treatment did they have? And whatever happens, how complex the case would be, remain calm, composed. Even if you don't finish the history of the examination, you're not meant to finish all of it in 5 minutes. If you have a complex case, it would take you longer in real life. And avoid rushing. You can lose easy mark if you start to rush your patient. And then you can come across a bit abrupt. So listen, calm, confident, show how you do it on your normal day practice. Then why are we doing this lecture on intermediates? Intermediates are very vital component of the Part 2 exam. Candidates often neglect these stations because you focus more on the viva and the short cases, and it could be a big mistake. There are 2 stations, and this is an excellent opportunity to score 7 or 8 if you approach it strategically. The structure of the intermediate and scoring. So start with 5 minutes to take history, 5 minutes for the exam, then 5 minutes for the discussion. 90% of the examiners would guide you. If you've gone above 5 minutes, they will say move on to examination. In rare occasions, they would leave you to lose the time, and that can be tricky. So by practicing, you would time yourself. So you're starting with a history focused and make it focused and structured. So then you would follow this with an examination. You have to be gentle when you do your examination, systematic and attentive to your patient. Tailor your examination to the complaint. Maintain the professionalism and coming across confidence all the time. Then you would tailor your management to the patient findings and what you know from evidence-based guidelines, and keep the patient as the center of your conversation. So even if you're discussing the management, you can look at the patient back and explain what you find on their x-rays. And I think that might give you an extra marks. In one intermediate case, you have 12 scoring opportunities. And in the scoring sheet, the first scoring point is history, then being able to formulate a differential diagnosis, then how fluent is your examination and structured, investigation, if any you are ordering the correct one and being able to interpret them, then knowledge and bedside manners and professionalism. So if you treat the patient professionally and be nice, kind, don't cause them any pain, and you score 7 out of 8, that can be enough to cover any knowledge gap if you get 5 out of 8 in your knowledge. So the key here is just treat it as how you normally treat your patient, and stay professional, calm, confident. History taking. You're not examined data history as a medical student. You're examined as a day one orthopedic surgeon. So start by introducing yourself, build a rapport with your patient, but yet you still need to show you are systematic. So use a Socrates framework, explain the pain, to explore the pain and function limitation. Uh, then, ask if they had any treatment history, and whether this conservative or operative measures. And finally, you need to summarize the history to your consultant. Overall, maintain patient-centered approach, show clarity uh, in your history taking. When you move to examination, you'll inspect, palpate, and move. Generally, have to be systematic, thorough. It needs to be focused on your patient complaint. You may need to mix more than one system if they have neurological symptoms in their hands while they're complaining of shoulder pain. So they may come with more than one pathology, but you have to tailor it to uh, what is relevant to your management plan. Be mindful of patient discomfort, ask about their pain, proceed cautiously with consent to ensure empathy at all times. For day one, my advice is to utilize a study group. So practice intermediate scenarios in a study group and use the past cases that came before. Prepare a station with your colleagues, and that would simulate uh, the real exam. Time management is a key. So always time your intermediate practice. You can time yourself in clinic. Um, then while you while you're practicing, just tailor your response in a way to show your depth of knowledge. So when you say I'm gonna order an X-ray, so this you have to be very specific. If it's a knee, I get a Rosenberg view because this would give me a good idea of the degree of arthritis in the medial lateral compartment. This is done by patient is uh, in standing in flexion 30 to 30 degrees. Or I'll get an MRI scan. I would expect on the sagittal plane and find this, but I would like also to roll this. So tailor the response when you have the discussion with your examiner to show your depth of knowledge, like the Viva. Um, refine your clinical exam skills in the next few weeks by attending specialist clinic, uh, do it in your family members, and practice it with your friends. In the discussion, you have to come across a day one consultant, which means you would give your examiner only a summary of what is relevant. So in the history, this patient is coming with a medial side knee pain at this age. On my examination, intact collaterals and ACL with range of motion of more than 90. In this patient case, as they are not a manual worker, I could offer them this treatment. So you summarized all high order thinking, history, exam, and discussion in one big statement, and you are at the 7. Then engage the patient. You can engage them in the discussion uh, as if you are doing it in real life. If you know guidelines, mention it. You don't need to quote papers, but quote guidelines. When you practice it, simulate simulate the station as a real exam. Get one of your consultant to be your examiner, and do it in a patient that you don't know their history. Uh, Practice it with peers, practice it in clinic. Um, Focus on the basics, avoid overcomplicating straightforward cases just to maximize your number. So I had olecranon bursitis in my upper limb intermediate, and my managed plan was to discharge the patient because they are now asymptomatic. Um, and that was it. Then the discussion, I was asking questions about the pathology, the condition, the risk factors, but do not shy away from discharging someone in the exam if the surgery doesn't has a minimal role in their case. In summary, the intermediate station is a valuable opportunity to score high in the exam. You need to dedicate time for preparation. Keep repeating your practice. Make sure it's a patient-centered approach throughout the station, and I'm sure you will excel in the station and score high. Any questions so far? Fine. We carry on. I'll just give you an example of how would you assess a hip, knee, and foot and ankle, and this is based on Fazal Ali book. So you take a history, or you would mention to the examiner, I'll take a history, and that more relevant to the short cases. Then in your clinical exam, step one, send the patient and look. Then I would walk the patient and look, do a Trendelenburg test, do a Thomas test, lying down, leg length discrepancy after squaring the pelvis and mirroring the deformity, do feel palpation over ACES and GT, range of motion. You want to rule out if they got any adduction contraction, fixed flexion contraction. Then you would examine sciatic nerve, and if they're young, you can do Faber or Fada test. If they are CP kid, then you can talk about Duncan Eli and Ober's, all these fancy tests. In the knee examination, history, SIB1, stand them and look, walk them and look, sit down the patient and look, and you're looking at the J sign, you feel for any patella crepitus, and you can examine the extension mechanism. You lie them down and look, and you'll be looking for quads, wasting any small arthroscopic scars. Then you examine the ligaments, cruciate and collaterals. Collateral 0, 30 degrees, cruciate and posterior drawer, anterior drawer, then and Lachman pivot. Test is commonly asked in the shorts. You finalize it by doing specific test. If the malalignment, then you may need to go a rotational profile, Beaton score for patellofemoral, or apprehension test, like patella laxity. In foot and ankle, pretty similar. You would take a history, examine them, stand the patient and look, walk the patient and comment on their gait. You can ask them to do, at this point, do a special test, Coleman or single leg stand. Then you would also check the lesser toes. You check the sole, footwear, any mobility aids. You move the joints, feel it, do a full neurological exam, and you do any other special test. If they have like a bilateral cabovirus, you check the hand, check the spine. Any questions, guys? And that's it for my intermediate lecture.
Any questions? I know Ibrahim is a very good lecturer, so it's very clear. But come in and just ask anything unclear. This is very important. Intermediates uh, cover half of the clinical, which equal half of the viva. So a case of clinical equals a full station, like a full basic science, hands and beads. So it carries the same weight. Hands and beads carries the same weight of a single intermediate case. So what Ibrahim told you today can save you a quarter of the exam. So come on and ask if any question. If not, we'll carry on to practice short lower limits. Good. So as I told you, Ibrahim, you are very, very good. That's why
That's very kind. Shall we stop recording?
we do that.
So